So we kind of talked about the DSM and labeling and diagnoses last time, but we didn't get into any actual diagnoses or actual disorders. So I think today we should try to make a little headway on that. And then I'll let you guys be free and work on those research credits. So not last week, on Tuesday, we talked about the DSM, and that's this manual in this picture here. And this is a classification system for all of the different mental disorders. And there are several different classification systems, but the DSM is the one that we're going to talk about in this class. And it's the one that most psychologists are familiar with. So the DSM-5 is the 5th edition. And we're going to go through different groups of disorders. And I've arranged it, I've kind of color-coded it for you guys, so I'll just skip ahead to show you. Each group is in this light purpley color, and then specific disorders are this blue color. If you're colorblind, then that might not help you, but for everyone else, the purple slides are the group and the blue slides are specific disorders I want you guys to know about. So we're starting at the beginning chronologically, and this is also the first group of disorders in the DSM, and these are the neurodevelopmental disorders. So if you remember, I said on Tuesday, they arranged this manual so that it starts with disorders that would develop early in life. So neurodevelopmental disorders tend to be first seen in childhood, and they're more biologically based, so they tend to be things you're born with, certain abnormalities about the way your brain is wired, all these things that would affect you immediately as soon as you're born. So the neurodevelopmental are seen in infancy. Sometimes parents can't really diagnose these disorders until early childhood, when it starts to be more apparent that their child is having some sort of learning disability or issue. And these disorders are characterized by academic, social, emotional, and behavioral impairments. Sometimes there are delays in speech, in language, in motor skills, and in learning. And the two disorders in this category that we're talking about in our class are Autism Spectrum Disorder and ADHD. So in this group of disorders, there are others, but we're not going to go into those. Autism and ADHD are kind of two of the more common ones, so that's what we're focusing on in this class. And these tend to be, like I said, biologically based, so they can be lifelong, but often children, as they grow up, learn to compensate for the disorders, so they might learn to manage their symptoms better for some of these things, or they can change and fade as you age. So the very first disorder we're going to talk about is Autism Spectrum Disorder. And this is characterized by those social, emotional, behavioral, and communication impairments. So you may know someone with autism spectrum disorder, or might have someone in your family, and different people present differently. That's the case for the majority of these disorders. So these are some different symptoms that you might see in someone with autism spectrum disorder. They might have a disinterest in socialization. They might be really sensitive to touch or sensitive to their environment. A lot of trouble in understanding feelings and social cues, especially feelings of other people, and reading facial expressions and understanding, okay, this is what that other person is feeling right now. They might engage in repetitive movements. They might need to have a very specific routine and feel distressed when that routine is not kept. They might have a specific intense preoccupation or fixation, and they might be hyper or hypo-reactive. So hyper-reactive, you'd be extra sensitive to your environment and to different stimuli, and hypo, you would be undersensitive to that. And so again, you can see in the name, autism spectrum disorder, it exists along a spectrum, so there's an entire range of impairment that can happen there. It affects about 1% of the population and rising, and it's unclear why it's rising. That might be simply because we're better at diagnosing things now and more aware of the disorder. So it might not necessarily be that there are more and more people with autism spectrum disorder being born. It might just be that we are stigmatizing mental health less, and we're more aware of different disorders and better able to catch them early on. So I have a short video of an example of what it might be like to experience some of this hyperreactivity and sensitivity. I'll post that on D2L. I'm not going to play it for you guys just because you guys have given me the feedback that it lags. So I'll post that online. You can watch it. Kind of interesting. If you don't know a lot about autism, it's nice to get a really visual perspective of what that might be like. The other neurodevelopmental disorder we're going to cover in this class is attention deficit hyperactivity disorder, and it's known as ADHD, probably what you've heard it as. And there used to be a diagnosis for ADD and a separate diagnosis for ADHD. That's no longer the case. So now it all falls under the umbrella of ADHD, and you can have different specifiers. So some people might be ADHD inattentive type. Some people might be more hyperactive and impulsive. So instead of being diagnosed with ADD or ADHD, now it all falls under ADHD, and different people have different presentations of the disorder. So it's characterized by a persistent pattern of inattention and or hyperactivity or impulsivity. So it's interesting to note that you actually don't have to be hyperactive to have the disorder, this disorder. It can be either or. So you might have the inattentive symptoms and not the hyperactive symptoms, and vice versa. So when you go through the DSM, all these different disorders have a whole list of criteria. And when a professional is making a diagnosis, they make sure, does this individual meet those criteria? And so they see if they meet enough inattentive criteria or enough hyperactive criteria or enough impulsive criteria to meet this diagnosis. And this, again, is a neurodevelopmental disorder, so it usually appears in childhood. It's usually first obvious in school when children start to struggle with either doing not so interesting tasks like homework or things where they have to sit still for prolonged periods of time. Sometimes children with ADHD, especially with hyperactive symptoms, struggle to even sit down in their seat during class. They might just stand up inappropriately. So when you think about children and the normal range of behavior, yes, to some degree, children are often very energetic. They are all over the place. This is a more severe end of that spectrum. So this isn't just my child is really hyper when they're at recess. This is something that's actually negatively impacting their life in multiple different contexts. So at school, at home, as an adult, at work, it's going to affect all those aspects of their life. And again, so clinicians specify whether the individual is primarily inattentive, primarily hyperactive and impulsive, or you can have a combination of those symptoms, which is most common. So as long as you meet the check box for enough symptoms, you are meeting the criteria for this disorder. And so symptoms fall under those three different headings. And this is generally considered a lifelong disorder. So again, those neurodevelopmental disorders are more biologically based. So they're not necessarily caused by an event or something in the environment. They're more likely to be caused by some sort of brain abnormality. So it's generally a lifelong disorder, but individuals may learn to better manage their symptoms with age, or their symptoms may change and fade as they get older. So in some adults, they still have ADHD, but just throughout their life of school and work, they've learned maybe little tricks or ways to deal with those symptoms. If someone is very forgetful, maybe they've learned to always leave their keys in the same place. Things like that that you might learn as you age. Is there anything else I want you to know about this one? In adulthood, Impulsivity might remain more of a problem than hyperactivity, and that might be due to simply understanding social norms. So understanding, okay, it's not generally acceptable to randomly get out of my seat in a meeting, but they might struggle more with those impulsive symptoms, maybe struggling with substance abuse or being unfaithful in a relationship or other impulsive risk-taking behaviors. Okay. I think that's everything I want you to know about ADHD. So let's move on to the next group of disorders. Okay. So this group is classified as Schizophrenia Spectrum and Other Psychotic Disorders. So that's the overarching heading of this section of disorders. You guys have probably heard of schizophrenia. There are some other psychotic disorders that fit under this umbrella, but we're mostly going to focus on just schizophrenia. But know that there are other disorders that can cause psychotic symptoms like hallucinations and delusions. Schizophrenia is not the only one. But schizophrenia is a rather severe disorder. It's characterized, well, let's talk about all of them first. So they're all characterized by a loss of touch with reality and difficulty thinking and communicating effectively. So abnormal thoughts and then some abnormal speech patterns can become apparent. We have what are called positive symptoms and negative symptoms. Positive symptoms you can think of as being added. There's something new. They weren't present before the disorder. Versus negative symptoms, there's normal behaviors that are absent. And it's something that an individual would usually be doing, but they are no longer doing. So some examples of positive symptoms are delusions, hallucinations, disorganized thinking, and that can often come out in what's called a word salad, so speaking in a very jumbled way. Grammar doesn't necessarily make sense, or sometimes people will talk very circularly, sort of start off on a topic and then go off on a tangent and either maybe keep going off on more tangents or finally circle back to the original question or thing they were talking about. But it's very disorganized, or word salad, it might be almost nonsense. And they can also have abnormal motor behaviors. Those are all examples of positive symptoms in that they were not present before the disorder. And negative symptoms are things that the individual is not doing that would be normal to do. So diminished emotional expression, also called flat affect. They might seem very unemotional and flat. That's not a normal presentation of emotion. Usually there would be some emotion there when experiencing either good things or bad things. In this negative symptom, there's a diminished emotional expression, so that is gone. Individuals can also experience avolition, and this is decreased motivation, and alosia, which is a reduction in speech, or sometimes called poverty of speech. And so they might speak very little. Plug my laptop in here. Yep. Okay. So schizophrenia is the only psychotic disorder we're covering in this class. And this is a severe psychotic disorder characterized by disturbances, again, in thought, perception, and behavior. And the DSM, again, lays out the criteria that you need to be diagnosed with schizophrenia. And you need 2 or more of the following symptoms for most of a 1-month period. So this has to be happening the majority of the time. You have to either have delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and or negative symptoms. And so delusions are strong beliefs not founded in reality. And delusions can be a little bit tricky to diagnose because at what point is something just a very uncommon belief? At what point does that become something that's not founded in reality? So you guys have probably met people that have talked about a conspiracy theory or believe in a conspiracy theory, it can be difficult to diagnose at what point that sort of thinking becomes delusion. And sometimes clinicians need to use their subjective judgment to diagnose delusions. So delusions are one possible symptom. Hallucinations, those are sensory experiences that don't have a source, and they can actually be from any of the senses. So you can have visual hallucinations, you could have auditory hallucinations, which are the most common. Oftentimes in schizophrenia, auditory hallucinations are going to be of a negative nature. It might be the individual hearing voices saying bad things about them, or just a sort of negative tone. So auditory hallucinations are the most common, but you can also have hallucinations of your other senses. You can have tactile hallucinations, like a feeling of something crawling on you or touching your skin. And you can also actually have hallucinations of smell and taste, but those are much, much more rare. Okay. You can also have disorganized speech. And an example of that would be that word salad, so that unintelligible mixture of words and phrases, grossly disorganized or catatonic behavior. Catatonic behavior is going to be very, very slowed down, very little movement. Disorganized behavior might involve abnormal motor movements, maybe strange movements that don't seem to have any purpose, might be very jerky. And then those negative symptoms, things like the alogia, the avolition, those decreased speech and motivation. So to be diagnosed with schizophrenia, you need at least 2 of these 5. You can have more than 2 as well. So it's not a very common disorder. About 0.3 to 0.7% of the population will develop schizophrenia, and it's a little bit more common in men than in women. The onset is usually in your mid to late 20s. So you guys might be entering that age in your life where you're at slightly higher risk of schizophrenia just due to the average age of onset. So you may end up in your life knowing someone that develops this illness. An earlier onset is associated with a worse prognosis. And prognosis is basically the course of the disease, or the course of the illness. So earlier onset, meaning if you develop schizophrenia at an actually very young age, you're going to have a worse prognosis than someone that develops it later on. So if you happen to develop it in your preteens or teens, which is not as common, that is associated with worse outlook than someone that might develop schizophrenia in their late 20s. And again, it can present in a variety of ways. So for all of these disorders, there's often a combination of symptoms that you can have. So you could have hallucinations and delusions, but not any of those others. So it just depends what combination of symptoms the person is exhibiting. Okay. You guys have any questions so far? I know it's just a few of you. So the next group of disorders are the bipolar and related disorders. And the manual goes in a sort of an order. I didn't mean to skip ahead there. So we started out with those neurodevelopmental disorders. Again, we're not hitting every group, but then we talked about psychotic disorders. Bipolar and related disorders come next, and bipolar disorder can sometimes involve psychotic features in bipolar 1. So the way the DSM is laid out is kind of intuitive in that it sort of flows from group to group that are a bit related to each other. So bipolar and related disorders includes bipolar 1 and bipolar 2, and those are the ones we will be focusing on in this class. In order to understand bipolar, you need to understand these different types of episodes that individuals can experience. So you can experience a manic episode, You can experience a hypomanic episode, and you can experience a depressive episode. A manic episode is a distinct period of increased energy and activity. And when I say increased energy, I don't just mean you're feeling pretty good today, you woke up refreshed, and you might go for a walk. This is a very high level of increased energy. Sometimes people going through a manic episode don't need to sleep at all for days, and they don't sleep and still feel awake and fine. So they need less sleep. They might talk excessively because they have so much energy. There tends to be impaired judgment and risk taking. They tend to feel really confident, maybe overconfident. That might have to do with some of the risk taking. Manic episodes can sometimes feel good. People feel like they can start all these projects and they want to do lots of different activities and perhaps be really social. It can include psychotic features. So that is the manic episode. The more severe type of mania can include psychotic features. And in order for something to qualify as a manic episode, it has to last for at least a week. Or if it doesn't last a whole week, the individual needs to be hospitalized because of it. So at least a week or more, or it caused hospitalization after fewer than 7 days. So that's an overview of what a manic episode is. A hypomanic episode or hypomania is basically just a less intense version of mania. So think of what we just talked about, but taking it down a few notches. So less intense mania, there can be no psychotic features in a hypomanic episode. And this one only has to last a few days. I believe in the DSM it's 4 days at least for it to qualify. So people having a hypomanic episode are still going to feel really good and energetic, confident, increased energy, all the same things, but to a less extreme degree. And then finally, a depressive episode is marked by a depressed mood. There can be loss of interest or pleasure. There can be increased appetite or decreased appetite, which can cause an increase or decrease in weight. Insomnia or hypersomnia, so sleeping more or sleeping less, not being able to fall asleep or falling asleep too much. All these things can change. Feelings of worthlessness and guilt, and then possible suicidal ideations and possibly acting on those suicidal ideations. So these are all aspects of a depressive episode. And so these different types of episodes are going to be included in diagnosing bipolar 1 and bipolar 2. Okay, so we'll talk about both. And I just want you guys to understand the difference. So in order to be diagnosed with bipolar 1, you must at some point have a manic episode. And so that means a truly manic episode, not a hypomanic episode. So bipolar 1, you have to have a manic episode. People that suffer from bipolar 1 are more likely to be hospitalized, and the onset is usually in the early 20s. The first episode is usually a depressive episode, and the nature of bipolar involves cycling back oftentimes back and forth between manic and depressive episodes. So someone can have a manic episode, it slowly goes away, and then they fall into a depressive episode, and there can be some time of normal mood in between those as well. But quite often, people cycle between the manic episodes and the depressive episodes. And again, for bipolar 1, there has to be a fully manic episode. So you can see in this graph on the right, if the red line is a typical mood range, and again, I'm sorry if any of you guys are colorblind because I'm realizing some of these things will not look like anything. But if you're not, the red line is a typical mood range. We all have some ups and downs. It's not going to be perfectly flat. And then the green line is a bipolar 1. So it goes all the way up past a typical positive mood to mania, and then falls all the way down to a depressive episode and can go back up and down. Bipolar 2, on the other hand, can never have a manic episode. So if you have a manic episode, you are automatically going to fall under bipolar 1. Bipolar 2 must include hypomania and a depressive episode. So it can't just be depressive episodes. That would be a depressive disorder. It has to include that hypomania in order to be bipolar 2. And these depression episodes, these depressive episodes, usually last longer in bipolar 2, and they tend to occur more often. Sometimes people think of bipolar 1 as being more severe, but both are basically bad in their own way. So bipolar 1 is quite severe because individuals experience that through full mania. Bipolar 2 is quite severe because they tend to have more depressive episodes and they last longer. So if you think about it, they're spending more time feeling bad than people suffering with bipolar 1. So there are actually higher mortality rates for people suffering with bipolar 2 than bipolar 1. So you may, I don't know if you guys have heard of the distinction between these before, but if you've ever heard of one being more severe than the other, that's not necessarily the case. Both are very difficult for different reasons. And again, we have this graph here with the red indicating a typical mood range. The green line is bipolar 2, and it doesn't go up quite as high as that last graph. It's only going up to a hypomanic episode, but then it still falls all the way down to that depressive episode and cycles back and forth. So bipolar 2, you have to have hypomania and you have to have a depressive episode. Manic episode, bipolar 1. So I might ask you guys a question about that on the exam and make sure you understand the difference between the two. And again, here is another graph, and I just think these illustrate nicely what the difference is between the disorders, and sometimes when it has that middle range, what normal mood is like. And then here we also have unipolar major depression rather than bipolar. So again, bipolar 1 goes all the way up to mania, all the way down to depressive episode. Bipolar 2 only goes up to hypomania, but all the way down to that depressive episode, maybe a little longer in that depressive episode. You can see it's lasting quite a long time. And then the unipolar depression is not experiencing mania or hypomania at all. You can imagine normal mood is going to be somewhere in the middle here with some ups and downs. Okay. So the next section we're going to talk about is depressive disorders. And we all get sad sometimes, and we all might say we feel depressed sometimes. But I want to make sure you guys understand that depressive disorders are beyond just feeling sadness. So sadness is a completely normal emotion. Everyone feels sad sometimes. Depressive disorders are a clinically significant, distressing, extreme level of depressive symptoms. And there can be a variety of symptoms. You can have depressed mood, loss of interest or pleasure, weight changes, sleep changes, psychomotor retardation. So that's kind of that slowing down of movements, or agitation, so maybe moving more or having, again, those jerky movements, loss of energy and fatigue, worthlessness and guilt, impaired concentration, difficulty making decisions, low self-esteem, and sometimes thoughts of death and suicidal ideation. And again, in extreme cases, someone with these suicidal ideations might attempt suicide. And I want to point out that, again, there are a list of criteria and symptoms that an individual has to meet to be diagnosed with these disorders. So someone could be depressed, but not feel remarkably sad. So they might have kind of a loss of motivation and interest in things. They might feel apathetic. So not every instance of a depressive disorder is going to look like someone crying all the time with suicidal thoughts. You can have a varied presentation of these disorders. It might look more like just being tired all the time and having low self-esteem. So different individuals experience these disorders in different ways. And the depressive disorder that we are going to talk about is major depressive disorder. And if you guys have ever heard of someone saying major depression, that's what they're referring to. They're referring to major depressive disorder. and it's abbreviated MDD. And this is probably one of the most commonly diagnosed disorders in the United States. So a lot more common, a lot more prevalent than something like schizophrenia. So about 7% of the population has major depressive disorder, and about 20% of adults will experience a major depressive disorder, a major depressive episode sometime in their life. So 7% is the prevalence at any given time. So right now in the population, 7% of people have this disorder. 20% is the lifetime prevalence. So 20% of adults will experience this disorder in their lives. So two different types of prevalence there. It often has an onset around your 20s, and women are 2 to 3 times more likely to be diagnosed with major depressive disorder. Some key features are that depressed mood, loss of interest or pleasure, sometimes irritability, changes in appetite, either increase or decrease, changes in weight without trying, and it can increase again or decrease, or increased sleep or insomnia. And there are physical symptoms like fatigue, and then cognitive symptoms like maybe that self-esteem is low, or maybe those thoughts of suicide. So lots of different variety of symptoms that can present themselves in this disorder. Okay. Another very common class of disorders are anxiety disorders. And this is the most common class of disorders in the United States. So of all these different types of mental disorders, anxiety disorders are the most common in this country. They're characterized by excessive and out of proportion fear and anxiety. And fear is a response to current threats, while anxiety is worry about future threats. So fear and anxiety, very similar. Fear is something in the present that's threatening you now. Anxiety is worrying about the future, like a test you have to take or a presentation you have to give, something that's in the future that you're worried about. And symptoms for anxiety disorders can also be varied. You can have physical symptoms and or cognitive symptoms, and a lot of people have some combination of both. First, we're going to talk about phobias, and you guys have likely heard the word phobia before. A phobia is a fear or anxiety about a very specific object or situation. So in my picture here, my example is this woman has a phobia of flying on airplanes. A phobia is something that always or almost always causes the fear response in the individual. It's actively avoided or endured with extreme discomfort. So someone might actively avoid ever flying anywhere. They might drive everywhere they need to travel. Or if they do fly, they're going to endure it with extreme discomfort. And there is disproportionate fear and or anxiety for what the threat actually is. So you guys may have heard that statistic. You're more likely to be in a car accident than have your plane crash. So worrying about that to this extreme degree would be disproportionate to the actual threat that exists. And one treatment for phobias is systematic desensitization. So I think we talked about this a little bit in the other chapter, but it's very effective to expose people to their fears. It works very well. And systematic desensitization is basically walking them through that fear in steps. So if you had a phobia of dogs, starting out with something that is less scary, like just looking at a picture of a dog, then working up to watching a cartoon dog show, then watching a real life dog show, and then going to a park with a dog walker, and then petting a dog. So you can see systematic desensitization involves working up to the phobia in steps. And research has shown that exposure to fears when done appropriately is extremely effective in treating phobias and treating fears. There are some other treatments that involve exposing the person all at once, but you have to be careful when using that type of treatment that there is not some sort of negative outcome. If I expose you to a dog that you're afraid of and something bad happens, like it happens to bite you, that is not going to help you overcome your phobia. That's only going to reinforce it. So if you do expose the person all at once, you need to be careful about making sure that there's not going to be any sort of negative outcome that they're going to associate. Okay. I think we're going to do OCD, and then maybe we'll stop and let you guys work on those research credits. Okay, so the next section we're going to talk about are obsessive compulsive and related disorders. And these are characterized by, it's in the name, obsessions and compulsions, excuse me. And obsessions are these recurrent, unwanted, and intrusive thoughts, fears, urges, or images. So an obsession is often something that someone doesn't want to think about, but the thought just pops into their head. It's intrusive. It could be something like a violent image, an uncomfortable image, an inappropriate sexual image, or just some sort of other unwanted urge, thought, thing that you don't want to think about. So obsessions are the cognitive component, and then compulsions are the behavioral component. And compulsions are repetitive behaviors that the individual feels driven to perform in response to an obsession. So if someone has an obsession, they then have a compulsion that they feel driven to perform. That's the behavior in order to make the obsession diminish or go away. And the compulsion can be related to the obsession, or it can be completely unrelated. So trying to think of an example. So if you have a intrusive thought about leaving your oven on, one compulsion that is related to that might be to go check your oven over and over again and make sure it's really off. That would be related. An unrelated compulsion might be an unwanted or intrusive fear that if you don't do something, your family is going to die that day. So maybe you feel a compulsion to flip a coin a certain number of times, otherwise something bad is going to happen to someone you love. So that would be an example of a compulsion that is not at all related to the obsession. So flipping a coin isn't related to something bad happening to your family, but the individual still feels driven to do that behavior in order to get rid of and quell that anxious obsession. And there are actually a whole group of different obsessive compulsive disorders. So there's OCD, which we're going to talk about. There's body dysmorphic disorder, and this is when an individual feels that there's something wrong about a very specific body part, and they think that it is deformed or looks very abnormal. And this is usually the case when there's not actually something statistically abnormal about that body part. So they might have a very average looking nose, or maybe it's only slightly large. If they have body dysmorphic disorder, they might think that it is extremely large. It's all they can focus on. They have obsessive thoughts about it. They might constantly check their nose in the mirror, things of that nature. Hoarding disorder, basically what it sounds like. So compulsively hoarding items. Trichotillomania is also related to obsessive compulsive disorder, and that is compulsive hair pulling. And then excoriation is compulsive skin picking. So those are both behaviors that are related to obsessive compulsive disorder. They're in the same group, and there is some evidence to show that they might be related biologically. So there might be this similar underlying biological cause. Okay. So obsessive compulsive disorder is the obsessive compulsive disorder that we're going to talk about. It's abbreviated OCD, and individuals can have obsessions, they can have compulsions, or they can have both. And oftentimes they will have both. The compulsions are very time consuming. So often it's things that might make their getting ready in the morning might make that take a very long time. I've heard of some people having clients that it took them an hour to walk to class because they had to walk to class a specific way, and they had to step on the sidewalk in a very specific way, something that would usually take 10 minutes maybe to walk across the Radford campus, instead ends up taking an hour. And they can sometimes include dysfunctional beliefs. So things that aren't grounded in reality, like that example of having to do something where my family will get hurt, where I have to check the stove is off exactly 15 times or my house will burn down. So these dysfunctional beliefs can fuel those obsessions and compulsions. And I'll post this video. It's actually a really interesting video of a girl with OCD. She has a pretty severe case of OCD. And then this comic on the right is also about OCD. It's interesting to note there's actually some biological treatments for OCD, some brain stimulation. So inserting surgically electric currents basically in your brain can help treat this disorder. So it is somewhat biologically based, and there are some surgical treatments that people have found are very helpful. That would probably not be your first line of defense. You wouldn't want to go off and get surgery as your first option, but for some people with really severe cases of OCD, that really helps them. Okay. So I'm going to skip ahead to the assignments before I let you guys go. So I hosted a new extra credit. This is the last extra credit of the semester. It's worth 5 bonus points. And I want you guys to do this if you want the bonus points, but it's also just a really positive activity. So positive psychologists believe that rather than focusing on mental illness and what's wrong with us, it's also helpful to focus on our strengths. So this assignment involves you taking a really short survey to identify your top character strengths. And this is something that comes from the field of positive psychology. So I have the link here, and it's also posted on D2L in the assignments. And you have to register with an email address, but it's completely free. They just make you register, and I believe that's because they're doing research, so they're trying to keep track of participants. And your results give you your top character strengths. They say that everyone has every character strength, but we use them in different orders, and we have different preferences and strengths that we're better at or less developed at. So this gives you your character strengths in order from highest to lowest. And for this assignment, it's pretty simple. You just list your top 5. So in a Word document or Google Docs or whatever it may be, you list your top 5 character strengths. And then for each strength, you write 1 to 2 complete sentences about either how you use that strength in your own life, or if you don't use it right now, how you could use it in the future. And so if you think about it, you're really only writing 5 to 10 sentences. It's not that difficult. So I really encourage you guys to do that for the bonus points. And it's going to be due next Friday at 11:59 p.m., so before midnight. And that's just because that's the last day of classes. So I don't want to be getting late submissions because grades will be due soon. So make sure you get it in by that last day, and it's worth 5 bonus points. And I have just an example here of what that would look like. So if you were writing about appreciation of beauty and excellence, which is one of the possible character strengths, I have just an example couple of sentences here. I use my appreciation of beauty and excellence to see the best in others. The strength is an asset in my work as a counselor because it allows me to see the best in my clients and to help them bring out the best version of themselves. This is just an example. And there are different strengths, so that one might not pop up as your top 5. There are a whole plethora of things like wisdom, curiosity, humor, I believe is one. So whatever your top 5 are, you'll write those 1 to 2 sentences about them. And then our normal remaining assignments I have laid out for you guys here. Exam 4 is on Thursday, May 7th, so that's finals week. And our exam time slot is at 10:15 a.m. And I want to keep it at that exam time in case you guys have other classes that are after that. So 10:15 a.m., which is not our normal class time. Then the reading homework for chapter 14 is due Tuesday before class. Chapter 15 is due Sunday, May 3rd by midnight. So that's a weird time. We don't usually have things due on Sunday, but I wanted to give you guys enough time to get that done, but me also enough time to put the grades in. So make sure you're keeping up with that. We just went over the optional extra credit. And then your SONA research credits, which is what I'm going to release you guys to work on now if you want to knock one out. So remember, you need 6 of those, equivalent 24 course points, and they're going to be due that last day of classes. I was warned that as students finish their studies, as they finish collecting data, they might take their study down. So that's why I want to let you guys go work on that. And just make sure you're not leaving it till the last day, because I worry if you do that, there won't be enough studies for you to get them all in. Okay. So does anyone have any questions? I'm going to stop my screen share here about the course schedule or anything they're worried about the exam or the material. If not, you guys are free to go, and I'll post this recording. Okay, cool. Well, you guys have a good day.
See you guys.